To study anesthesia, and we are going to do rapid revision of anesthesia. And first we need to know why we do anesthesia, and we will we will try to cover all PYQ and PYTs of the exam. And let's see, and I will tell what is the important for exam and what is not important. We will cover in this exam, in today's topic. Okay, so let's start. Like, first is why we need anesthesia. This is not important for the exam, but we need to know why we are giving the anesthesia. And the first thing is for pain relief as analgesic. Second is loss of reflex response like cough, airway, laryngeal. This reflex we don't need during the surgery. And amnesia, no memory. We don't want to remember the procedure of surgery, so anesthesia help in this process. And muscle relaxant, we don't want resistance when we do surgery, so anesthesia also relax the muscle. Now we are going to study types of anesthesia. Types of anesthesia: generals means we will give anesthesia to all body. And regional, particular any part. And monitor anesthesia care, monitor anesthesia care, we monitor the patient, and if they need anesthesia, we will give. If they don't have any critical situation, we will not give to anesthesia to the patient. We only monitor the patient, so this is called monitored anesthesia care. Now what is general anesthesia? I already explained what is general anesthesia. In this we include pre-anesthesia evaluation, pre-medication. First we will evaluate the patient before anesthesia. After we give medication before outside OT, like anxiolytic, imidazolam, and tablet aprazolam. They are benzodiazepine and anti-sialogogue agent, and like atropine glycopyrrate, anticholinergic. Then antacids, which decrease acid production in stomach, is PPI, hydrogen pump antagonist. Antiemetics, dexamethasone, and prokinetics, dexamethasone prokinetics 5-HT antagonist. These are the medicine which will give outside OT for pre-medication of before surgery or anesthesia. Then procedure of general anesthesia. Procedure, we are going to study the procedure. This is the important topic. What is the monitors in OT table? This is the topic where we can get the question. Then the monitor, in monitor, what we can see. This is the question, exam question, visual question. I can mark like VQ. This is visual question. They ask what we see in the monitor. You can see first the heart rate, then NIBP. NIBP is the non-invasive blood pressure monitoring. IBP is the invasive blood pressure monitoring, which is in the red color. And ETCO2, which is in the, you can see square shaped graph, which is ETCO2, or we can call capnograph. This is very important, capnograph. This image is very important. And before we going to further, I want to let you know denitrogen. Before we going to anesthesia, we will do denitrogenation or pre-oxygenation to the lungs. Like we will, for example, now when we are breathing the normal air, in normal air have 70% nitrogen, and remaining all are approx 70% nitrogen and 78% nitrogen and 21% oxygen. But we want, so this time in our lungs have only 21% oxygen. But before anesthesia, we want to fill the lungs with 100% of oxygen by mask. In 3 minutes we will do this. Now this is important question. This whole page is very important. This is the color of cannula. Color of cannula, they ask in every exam. They ask question from color of cannula, because this is very common things we use in our practice. So like different size of, you can see mnemonics. This is IV cannula mnemonics. Like you can see the size from 14G this is the biggest site. You don't go through the on the number. Less number is more size. Less number, more size. More size means width. This. So 14G is the largest, and then 16G, 18G, 20G, 22G, 24G. This is the before this year. Now they add. Now two new cannula is added. One is this one. You can see here, new cannula. This is white. Is 17G is newly added, and violet. This is newly added. Now when they ask question which is the narrowest, narrowest is violet, narrowest, and widest is orange. You need to remember this, and you don't need to remember size. You don't need to remember flow rate, but they didn't ask flow rate. But if you want to remember, you can remember green. Flow rate of green is 103, and flow rate of pink is 67 ml per minute. This is important if you want to remember. And here is the mnemonic. Like you can imagine, this is a earth, and downside of the earth is lava layer, and lava you can imagine is orange. So first layer is orange, and after they have soil, the color of soil is gray. So here is the gray color, and after green, grass is green. On the soil have grasses, and on grasses have flower which is in pink color. So here is the pink cannula, and after you, when you go up, there is a sky, and the sky is the blue, and after sky there is the sun is yellow. So you can remember like this mnemonics, different cannula, and this is very important. Every exam asks this question, and now two cannula is newly added, so they are also important for the exam point of view. One is the white and another is the violet. Now the steps of anesthesia, which steps you like, this page is very important till now. And steps of anesthesia, like induction of anesthesia, how you induce the anesthesia. You can induce by the IV induction agent and the inhalational agent. You can understand by yourself, like when IV we give something IV like directly into the blood, they will work too fast, so it will work in 15 seconds, while inhalational agents you can give by nasal airway, respiratory airway. It take time to arrive in the brain, so it take time around 3 to 5 minutes. And here is the example. You need to remember propofol, ketamine, thiopentone, and etomidate. We will study further. These three are in the fun category. Ketamine have different category, and propofol, thiopentone, and etomidate have different category. We will see later. Inhalational agents, this fluorone, say sevoflurane and isoflurane, we can see what are there. Then what we use, this is the IV induction agent, inhalational agent, neuromuscular blockade or muscle paralysis, the agent which block neuromuscular junction, and after this muscle will get paralyzed. And patient with what happen when muscle paralyzed? Patient become immobile and muscle will paralysis, and we can do intubation easily. What is the intubation? When we do ET tube by laryngoscopy, we insert ET tube by laryngoscopy, and after ventilator we connect oxygen and inhalational agent for maintenance of the anesthesia. Yes, this, and you see oxygen is and nitrous oxide, this with inhalational agent. Oxygen and nitrous is carrier gases, we will see later. They are the carrier gases. And emergency from general anesthesia, if you get you are unable to do intubation, what will you do? You stop inhalational agent and give 100% oxygen, and you do reversal agent. What is reversal agent? Neostigmine and glycopyrrole. This is important, you need to remember from the exam point of view. Reversal agents are neostigmine and glycopyrrole. After you need to do post operative care. Now this is we see the steps for the general anesthesia. Now what is important in this, you can see in this you need to remember only this point. This is important. How you, first thing is you need to know how you manage emergency in anesthesia. When you are unable to intubate, you need to stop inhalational agent and give 100% oxygen, and after you need to give reversal agent these agents will reverse the effect of the inhalational agent, and these are the neostigmine and glycopyrrole. This is important, you need to remember from the exam point of view. This question asked many times. Then what is regional anesthesia? I already told you, when we want to block a particular nerve block, like central neuroaxial blockade and peripheral nerve blockade. In central, spinal axis, epidural, spinal anesthesia. This AX is anesthesia. I write for anesthesia this, and epidural anesthesia and caudal anesthesia. In this, like, you need to remember here the important things you need to remember is subarachnoid space and epidural space. This you need to remember. Okay, this is important question from the exam point of view, where we give epidural anesthesia and where we give spinal anesthesia. Spinal anesthesia we will give in the subarachnoid space, and epidural anesthesia we will give in the epidural space. Okay, and then caudal anesthesia and sacrococcygeal membranes. This caudal anesthesia we will give in pediatrics for children, and where we give in sacrococcygeal membrane epidural space. And here is the peripheral nerve blockade. Femoral nerve, like we block a particular peripheral nerve, like femoral nerve and sciatic nerve. What is the contraindication of the regional anesthesia? This is important, you need to remember. When patient don't want, patient refuse, patient say I don't want a regional anesthesia, then you cannot give. Local anesthetic allergy, when have allergy we cannot give regional anesthesia. Intubation at site of needle insertion you cannot give, and bleeding disorder like coagulopathy and platelet count is less, you cannot give. You will not give regional anesthesia. Now I already explained what is my monitored anesthesia. Clear? Here you need to remember where we give spinal anesthesia and where we give epidural anesthesia. We further see the layers of which layers we pierce during spinal anesthesia, and epidural anesthesia also important, we will see further. And now we know what is the contraindication. And monitor, I already told you, standby monitoring pain relief. This is the function, and this is the common point. Then never asked, but for anesthesia, if you want to know, you can know what is the father of modern anesthesia, or also called ether anesthesia, because ether they use as anesthesia first. So WTG Morton, World Anesthesia Day, 16 October 1846. Father of anesthesia, John Snow, because John Snow gave oxygen and nitrous oxide to Queen Victoria during the delivery for relieving the pain. So he know the father of anesthesia. The word anesthesia was coined by the Oliver Wendell Holmes and used Cura is the product, like curium. For the first time, the muscle relaxant is the Harold Griffith. You also listen the name of Griffith in one experiment. You can comment below where you listen Griffith, not Harold. You can listen the name of the Griffith. And we used local cocaine for the first time for the spinal anesthesia is August Beer. This you remember, not August, you need to remember Beer. We will further see the law, Beer's law. Okay. And first intubation done by William McEwen. Oxygen and nitrous oxide is synthesized by the Priestley. You need to remember this. This Beer. Here you need to remember Beer, and you need to recall who is Griffith. This is work for you. Okay. And not much things you need to remember. First demonstration by Horace Wells, and introduce chloroform. You often see in the movie what chloroform they talk about chloroform and use chloroform in kidnapping. The first use of drawn by James Simpson. This is not Simpson cartoon. And first anesthesia machine used by the Edmund Boyle. First Nobel Prize Bovart. World Anesthesia Day 16 October 1846. And Balance Anesthesia by Lundy. But what is balance anesthesia? When person is completely unconscious and he don't feel pain and muscle is completely relaxed. This is called balance anesthesia, and first it is demonstrated by Lundy. Here they didn't ask any question from their these topics. Now you need to, this is very important topic, different gas cylinder, because they want what is the color of a cylinder when you do intern. So like gas, oxygen, when have oxygen, the color of cylinder like this is cylinder and this is shoulder. Okay, this now like this you can see the color for oxygen. This shoulder is white and the body is black. Okay, this body is black. I can like black, and this is white. For nitrous oxide, blue. Everything is blue. All is blue. All is blue. All is blue. Not all is well. All is blue. For nitrous oxide, all is blue. So first you need you need something like, when you want to remember like something nitrous, only you need to remember blue. All is blue. Cyclopropane, all is orange. Orange. All is orange. Cyclopropane, they already asked about cyclopropane and nitrous oxide and oxygen because they commonly use. For carbon dioxide, all is gray. 1 minute, all is gray. I unable to find gray color, but like this. Okay, this is green, but you will remember carbon dioxide is gray. Okay, and for nitrogen, all is black. So you can see oxygen, nitrous oxide, cyclopropane, carbon dioxide and nitrogen. You can write like this. These have whole same color. All is for nitrous oxide, all is blue. All is blue. For cyclopropane, all is orange. For carbon dioxide, all is gray. For nitrogen, all is black. Okay, you don't need to remember like this. Have all shoulder and body same color. Now when you go, now you left with oxygen, air and Antonox. Antonox is also important. Also they ask question on the Antonox. Now you can see shoulder for air and oxygen is same, white and white, and for like shoulder for oxygen, air and Antonox same, white, and body is different. Only body is different, but shoulder is same color, white. So you need to differentiate by body color. Oxygen is black body, air is gray body, and Antonox is blue body, and their shoulder is white. So you can differentiate by this. You also need to remember pin index. Pin index is like this is cylinder, and cylinder have like socket. Different cylinder have different socket. Like air is 1.5, oxygen is 2.5, nitrous oxide is 3.5. So you can see 1.5, 2.5, 3.5. Air, oxygen, nitrogen. Air, oxygen, nitrous oxide 3.5, and nitrogen is 1.4. Oxygen, carbon dioxide is 2.6, and oxygen, carbon dioxide if carbon dioxide is less than 7.5%, 2.6. If carbon dioxide is more than 7.5%, is 1.6. sorry, what, not 1.6, 1 and 6. And for Intonax, they already asked question on this. This is important. Antonox and oxygen also important. Air and oxygen. This is important. 2 and 5. You need to remember this. Okay. Now, what is daycare anesthesia? Daycare anesthesia, it means you can the surgery will done in within 24 hours or same calendar day. This also name is the ambulatory surgery. Founder of daycare is James Henderson. Here, what you need to remember, this whole table is very important. You need to remember. Okay. Now, daycare surgery. Founder of daycare surgery James Henderson Nicole. And this you want to know. This you want to remember. If you want to remember, you can, or just read for the knowledge. This is daycare surgery, simple surgery. Source daycare surgery will be simple, short, and not complicated. And like this, I write some surgery which is like simple, short, and not complicated, like hernia surgery for general anesthesia, hydrocele, lipoma, in ophthalmic, cataract, in gynecology, hysteroscopy, colposcopy, and FET, ovum pickup, and in dental RCT, ENT, nasal bone spur surgery, and in pen clinic transforaminal injection, urology, cystoscopy, and orthopedic dislocation. Procedure, like first we do pre-anesthesia checkup, then day of the surgery, and after surgery we send him to recovery room, and after home discharge. This is only for your knowledge. Not much thing is important for the exam. This page. Now this is important. What is the contraindication of the daycare surgery? Where you cannot do the daycare surgery? And in preterm baby and mentally retarded. In 2% you cannot do daycare surgery. Preferred anesthesia technique for daycare surgery is regional anesthesia. This is you need to remember which technique in daycare, because regional anesthesia you can easily wake up the person after anesthesia. You can easily you don't need to wake up, because person is generally in regional anesthesia, person is already awake, and only you give anesthesia to the particular part of the body. So what this I mark this is very important for the exam point of view. The general anesthesia. Induction agents of choice during the day care of surgery is propofol, then opioid of choice remifentanil. You need to remember remifentanil. This is important opioid. For the muscle relaxant of the choice, succinylcholine or the procranium sugammadex. You need to remember this. Airway management, LMA or SAD. Okay, and inhalational agent of choice sevoflurane, and preferred agent of TIVA, total intravenous anesthesia, is the propofol. These all are the exam question you need to remember. Regional anesthesia, local anesthesia of the local anesthetics of the choice is the chloroprocaine. Spinal needle of the choice is 27G Quinky. Quinky is the cutting type of needle, like cutting knife of needle. You can see like this and this cutting type of needle, Quinky needle. Okay, this is important, and you need to remember this name also. Bromage scale. This is used for the assessing the extent of local anesthetic block, and FL score for the PONV. PONV means the post operative nausea and vomiting. This is the score, but you don't need to remember this. Only important you need to remember the name. FL score for the PONV, Bromage score for the anesthetizing, and Aldrete score for the recovery of the patient and home discharge. We will do after this Aldrete score. We will discharge the patient after Aldrete score, on the basis of Aldrete score. And what is fast tracking? What is PACU? PACU is the post anesthesia care unit. Post anesthesia care unit. And what is fast tracking? By passing PACU, it means you will not send the patient to the PACU. You directly send patient to the home. Then you can say this is post anesthesia care unit. Then you can say this is fast tracking. And most preferred LMA. this also again. Now these all are which in the box and I marking the stars. They are the important question for the exam point of view. You should need to remember this. Most preferred LMA is Prosil. Most common side effect of daycare anesthesia is drowsiness. Most common cause of delayed discharge is PONV. Most common cause of the readmission after daycare surgery is the bleeding and surgery complication. Like same after day of surgery. And what is IBP? IBP is an advanced anesthesia monitoring. What is IBP? Invasive blood pressure monitoring. This is not in general anesthesia monitoring. This is in the advanced anesthesia this is included in the advanced anesthesia monitoring. Okay. Now very important topic we are going to read, capnography. Every exam have question from this. What is capnography? Capnography we will measure EtCO2. When I show you remember this machine, anesthesia monitoring machine on the OT table. This machine, I show you, this is the EtCO2. You can see this is the EtCO2 graph, and this what the EtCO2 will measure. EtCO2 will measure the end tidal CO2. What is the full form of EtCO2? Is the end tidal CO2, and you can see the graph. You see like this. This is the graph. This is like not perfect square shape, but you can say like a square shape graph. And when you can see different phases in this graph, and say 4 phases. This is important, and have 2 angle, beta angle and alpha angle. So what is phase 1? What is phase 1? Phase 1 is this baseline, inspiratory baseline. You are doing inspiration. This is phase 1, and expiratory upstroke. When this phase 2 is expiratory upstroke, it means dead space exhalation, dead space to exhale karna. And then phase 3. Phase 3 is phase of alveolar ventilation. This is phase 3, alveolar ventilation. Okay, and phase 4. They all are the questions, and they already asked about phase 3. They already asked about the beta angle. They already asked about the EtCO2. So you should need to remember all. Phase 1, I already told you, inspiratory baseline. Phase 2, expiratory upstroke. Phase 3, phase of alveolar ventilation. Phase 4, beginning of next inhalation. And what is beta angle? Degree of rebreathing. Okay, and what is alpha angle? Alpha angle is the indicator of ventilation. This is the indicator of ventilation. This is the degree of rebreathing. You should need to remember. Okay, and EtCO2 is the CO2 exhaled at the end of phase 3. When this is phase 3, when you see here is the EtCO2. When phase 3 stop, and how much CO2 is exhaled is called EtCO2, and tidal carbon dioxide. Normal value of EtCO2 is 35 to 45 mg. This is also exam question. You should remember 35 to 45 mg. Okay, and alpha angle is the indicator of ventilation. I already told you. Types of capnograms. 2 type of capnograms. You don't need to remember, mainstream or side stream. Okay, mainstreams like only one pipe for both, for oxygen and exhale carbon dioxide, and for side stream we will do like different one pipe in the side. This is side stream and main stream. Okay, what capnography, what show, what we will know by this graph. We will go first. We all know EtCO2. It means end tidal CO2 carbon dioxide, and after also we know metabolism. We can know circulation. We can know ventilation. Okay, now we need, this is also important. These are the different type of capnograph. You should need to remember. We can see like for malignant hyperthermia, you can see like step ladder pattern. You should remember, and this they already asked about this. And what is the treatment of malignant hyperthermia? Malignant hyperthermia important for the exam point of view. You should know everything about malignant hyperthermia, and they show step ladder pattern, and treatment is dendrolium sodium. Esophageal intubation, falling of EtCO2. You can see when you intubate into esophagus, not instead of trachea, the CO2 will fall like this, falling into CO2. Then this is the, like, they also exam question. You see negative, when you see the notch like this, top up muscle direction, negative inspiratory attempt, like you have seen in the movie, they like this, they do like this for inspiration. This is negative inspiratory attempt. And allergic reaction, are when you see allergic reaction, they appear shark fin appearance, they show shark fin appearance due to bronchospasm. You can see shark fin appearance, and where you can see this shark fin appearance phase 2. You can remember, like allergy, they have double L, you can make like this, phase 2. Okay. And sudden drop in EtCO2, like they ask question, what is the cause of sudden drop of in EtCO2, or they can give you the case scenario. Then in that case you can do disconnected circuit. First cause is disconnected circuit, second is cardiac arrest, third is pulmonary embolism. This is the causes, and you can see the capnograph like this. Gradual fall in EtCO2. Okay, gradual fall in EtCO2. Hyperventilation. Why? You should need to remember why we have gradual fall. Here you see after one have flat line, sudden drop, and gradual fall. Hyperventilation, hypotension and bleeding, and where one thing more, wrong intubation, esophageal intubation. Okay, you should remember this. And rebreathing. In rebreathing, when you inspirate, exhale CO2, it's called rebreathing. You see when you rebreathe CO2, the amount of CO2 increase every time. You see the level of CO2 increase every time during rebreathing. And inspiratory valve faulty. If the valve is faulty, then you see the graph has slope like this. Okay. And when you see like this notch, this you can see, this is the cardiac oscillation, because in children heart beat too fast, so you can see the cardiac oscillation in capnograph. And double plateau, when you see double plateau sign in capnograph, this is the due to faulty EtCO2 sampling line. Okay, when you do faulty EtCO2 sampling, you can see notch like this, double plateau. Okay, these all capnograms are very important for the exam point of view. Now electrocardiogram, this you will also read in the medicine, but here for anesthesia, who is doing anesthesia, important here, they need to monitor ECG during the whole surgery. So this is also important here. Now when someone come to the clinic for ECG before operation or before surgery, we use 12 leads, V1 to V6, like V1, V2, V3, V4, V5, V6, and 1, 2, 3, and AVR, AVL, AVF. And intraoperatively during the surgery, we because we don't have much space, so only we use 3 leads, or when patient is like have cardiac problem something, we will use 5 leads. And now this is important, most sensitive lead to detect arrhythmia, which lead is more sensitive for arrhythmia. You can remember double R, like you can do like this, and again become lead 2. And most sensitive lead for detecting MI, for MI V4 and V5, but V5 is more sensitive than V4. If both are in the option, you will choose V5. Okay, then this I try to show what, like first lead, what they say, lateral wall EMI, lateral, and you can see First, AVL, V5, V6 show MI in lateral wall. Second, third and AVF show MI in inferior. V1 and V2 show MI in septum, and V3 and V4 show anterior. You will read in detail in medicine. Basic principle of pulse oximeter. Oximetry. You all, I think, know about the pulse oximeter. Now, what is the principle? This will work on the principle of the Beer-Lambert law. What is Beer-Lambert law? And first, where you attach pulse oximeter. Generally, we attach to finger, but we can also attach in toe, tongue, or ear lobe in case of children or some other condition. What is Beer-Lambert law? Beer-Lambert law is the red light. We have two type of hemoglobin. One is oxygenated hemoglobin, and another is the deoxygenated hemoglobin. So red light is absorbed by the oxygenated hemoglobin, and infrared light is absorbed by the deoxygenated hemoglobin. And what is the Beer-Lambert law? You need to remember, this is important. Plethysmography, signal from arterial blood. Now this is called plethysmography. Like when you are doing pulse oximetry. When you are doing pulse oximetry, when you attach the pulse oximeter to your finger, in the finger have both artery and vein, but the pulse oximeter only detect the oxygen from artery blood, signal from artery blood. This is called plethysmography. You need to remember the name only. And what is the co-oximeter? You need to remember this, also important. Co-oximeter also detects the hemoglobin disease. Like when have something pulse oximeter only detect oxygen but unable to detect disease, but co-oximeter also detects hemoglobin disease. Okay. Now BP monitoring we will do by the two methods. This NIBP, non-invasive blood pressure monitoring, and invasive blood pressure monitoring. Non-invasive blood pressure monitoring, the principle is important. Already asked in the question, what is the principle of NIBP? Is the oscillometry. Like in the veins oscillation. This is the vein, and in vein have blood, and when you apply pressure from outside, the blood start oscillation, and oscillation is recorded by blood pressure. Blood pressure monitor, sphygmomanogram. You already know about it. Use in the where IBP, where we use in ISD, ischemic heart disease, stroke, and organ damage. Put arterial cannula in. Where we put arterial cannula? In radial artery. This is important. Where we put arterial cannula? In radial artery. Okay, which artery mimics central waveform? Like aorta is femoral artery, so we also use for central line, we use aorta and femoral artery. Maximum chance of infection in femoral artery. Okay, because in the growing part. And now this all are the important question you should need to remember. Gold standard method for inserting central line is USG guided. Most comfortable site for long term CVC line. Long term तुम्हें बहुत लंबे समय तक की लगानी है, तो you don't want that it will disturb. Then the subclavian vein, this is the best choice because they have the support of the sternocleidoid muscles. Okay, confirmatory for the central line. Confirmation हमें करना है कि central line का placement सही हुआ कि नहीं हुआ, तो we can see by the chest X-ray. Ideal site for the central line tip placement is the right atrium. Okay, and pulmonary artery catheter. What is pulmonary artery catheter? This is the pulmonary capillary wedge pressure, and we can measure by the pulmonary artery catheter. This is very important. Bispectral index. You will see in the image. You can see the face like this, not like this. First, like this is the face. You can imagine this is the face of the person. This is the eyes and this. Okay, you see have like this, and here have something electrodes like this. Okay, This is bispectral index. We will measure the depth of anesthesia by the bispectral index. In short, we say BSI. This is an important question. We already asked. This question is already asked in the exam. Okay, and this is what another like this is device. इसके अलावा क्या करते हैं हम लोग? डेप्थ ऑफ एनेस्थेशिया नापने के लिए BIS, एंट्रोपी, सेरिब्रल स्ट्राइक एंड नार्को ट्रेंड. बट bispectral index, this is important for the exam. What is evok potential? Used in neurosurgery. When we do neurosurgery, we will use evok potential. And which is not affected, this is the question voice, which is not affected by the evok potential. Brain stem auditory pathway is not affected by the anesthetics agent. Okay. Then peripheral nerve stimulator. What is peripheral nerve stimulator? In neuromuscular junction monitoring, used in neuromuscular junction monitoring. And which nerve we monitor is ulnar nerve. You need to remember which nerve in Fmge we monitor ulnar nerve. Peripheral nerve locator. This device used for locating the nerve. Most sensitive method for invasive cardiac monitoring in ischemia. This is also important question. Most sensitive method for non-invasive cardiac monitoring in ischemia. And this is transesophageal echocardiogram. What is the transesophageal echocardiogram? This is the most sensitive method. Then American Society of Anesthesiologists. This is also very important, already asked question from this topic. American Society of the Anesthesiologists physical status classification. This they classify into the 6 category. First category, like fully healthy individual, don't have any problem. But and 6th category is the brain death people. Then you are thinking, why we give anesthesia to brain death people? Because for the organ harvesting. Okay, so first is totally healthy and the 6th is brain death. Now 2nd, 3rd, 4th, like first is I am healthy, 2nd I have some little disease like mild, 2nd moderate like little more, and severe like now some organ is damaged like kidney, eyes, some organ is also damaged or have strokes like this. Then and morbid end patient, like not expected to survive without surgery. If we will not do surgery, they will die. This is comes under the type 5. So type 1 is the healthy individual, type 2 is the mild, type 3 is the moderate, type 4 is severe, type 5 is morbid end, type 6 is the brain death. And one more type they add, like E means emergency. When they add like first E means individual is healthy but something is happened and we need emergency, like this. Okay, so this is important. They already asked question from here. Fasting guidelines. What is the fasting guidelines before the surgery? This is also important. Clear liquid like water and juice you can give up to 2 hours. Breast milk you can give up to 4 hours. And cow's milk or top feeds you can give up to 6 hours, or light meal. And full fatty meal you can give this before this all up to before 2 hours. Okay, here not up to, before up to 2 hours. So clear liquid like water, epi juices, Coca-Cola, like this, clear liquid you can do up to 2 hours before surgery. You can take up to 2 hours. Breast milk 4 hours before. Cow's milk or top feed or light meal you can take before 6 hours. And full fatty meal up to 8 hours you can take. Most common complication after surgery is post-operative nausea and vomiting. I already told you. This is also very important topic. Malam Patti classification. Okay. And they divided into class 4. Class 1 you can see this is class 1. In class 1 you can see everything you can see. Okay, and have one class more 0, class 0. In class 0 you can see epiglottis. In class 0 you can see epiglottis, epiglottis. And in class 1 mostly they ask about class 1 and class 4. In class 4 you can see nothing, only you can see the hard palate, you can see. And in class 1 you can see everything. And what you can see in class 0? Epiglottis. You can also also see epiglottis of the patient. Okay. And in class 1 have soft palate, you can see pillars are visible. But in class 2 pillars are not visible. Here you can differentiate, have pillars, this pillars is not visible here. Okay. And class 3 base of uvula visible, you can only base of the uvula visible and soft palate visible. And in class 4 only hard palate is visible. This is Malampati classification, is very important. They already asked question on this. Already asked question on the Cormack-Lehan classification. Cormack-Lehan classification is the when you do intubation, and during intubation you use laryngoscope. From laryngoscope you can see this. When you can see nothing, ना तो ग्लोटिस दे सकते हैं ना एपिग्लोटिस, neither glottis nor epiglottis. This is grade 4, and mostly in exam they ask about grade 4. They give picture and they say person is doing laryngoscopy, and they see image like this, and which is the classification. They can ask NAM, Cormack-Lehan, or they can ask which grade 4. And you can remember when you can see full glottis, like you can see everything, you can see here, this is full glottis, grade 1. When you see only posterior extremity of the glottis seen is grade 2, and only epiglottis seen is grade 3. Okay. What is thyromental distance? And this is also called Patil's test. You need to remember distance. This thyromental distance is more than 6.5 centimeter, and sternomental distance is also called Sava test, is more than 12 centimeter. Difficult airways, you don't need to remember, they don't ask any question, but this is the mnemonic for difficult airways, like mask ventilation. Difficult airway, when we feel this is difficult for mask ventilation, we apply the mask on the face of the person, but we feeling it is difficult. If the mnemonic is bones, when person have beard, or person is obese, or have no teeth, or elderly person, or have sniff lungs or snorer. Intubation. In intubation the mnemonic is lemon. You can say look extendedly. Okay, have evolution 3T2 low Malampati classification. Obstruction, neck, morbidity. Okay, like this LMA session, the mnemonic rods, and but you don't need to remember this. Okay, now this is important. Das difficult intubation guidelines. Okay, what is das intubation? Difficult intubation guideline. Like first you try to intubate by laryngoscope, and like you try 3 plus 1, like total 4 times, 3 times attempted by you and 1 time by your seniors. 3 plus, if success, then you do tracheal intubation. If you not such a fail intubation, you go for the supraglottic airway device, SAD or LMA. 3 times you do. If succeeded is okay. When you don't succeeded, final attempt at a face mask ventilation. If you success, now you not need to do surgery. You need to wake up the person. Okay. Also, when you fail in the supraglottic device, you need to wake up the person. And final is the cricothyroidotomy. Final, when person will not wake up and you fail, you need to cut in cricothyroid membrane. You need to mark a cut, and you need to do it fast. Cricothyroidotomy to save the life of the patient. Now, pre-anesthesia order regarding medication. Antihypertensive. This is very important. Every year they ask question. Antihypertensive drugs. which day we need to don't need to give omit on the day of the surgery. Don't need to, we will continue, but we will on the day of surgery we will need to omit ACE inhibitor and ARB, diuretics, beta blocker, calcium channel blocker, and central acting alpha 2 agonist. We need to continue till the day of surgery. Now, anti-diabetic drugs like metformin and insulin. No, we not need to give on the day of surgery, because patient will on the fasting and already have low glucose. And then anti-psychiatric medicine continue on the day of the surgery, because psychiatric medicine, patient already, every patient I think they are scared of the surgery, so we will continue anti-psychiatric medication on the day of the surgery, except lithium. With lithium we will omit 48 to 72 prior to surgery, and TCA tricarboxylic acids we can omit 2 weeks prior the surgery. So TCA tricarboxylic antidepressants we will omit 3 weeks prior to the surgery. Then anti-thyroid medication we will continue on the day of the surgery. OCPs, what is the complication of the OCPs? Complication of surgery is DVT, deep vein thrombosis. We will continue the OCP for short surgery, and for long surgery we stop 4 weeks prior to the surgery. Okay, you need to remember this, because here you have two choices. When have short surgery, you should need to continue on the day of the surgery, but when you have long surgery you need to stop 4 weeks prior because of the complication of the DVT. Okay, oral steroids continue on the day of surgery. Patient on AKT, when patient is on the TB drug, you should continue the drug, and you also need to do blood test for LFT. Cardiac patient, when you have cardiac patient and cardiac patient have bone metal stent, you should wait 6 weeks, and drug loosening stent you should 6 months you should need to do before the surgery, or you should need to wait for the surgery. Now want anticoagulants. Aspirin you can continue on the day of the surgery. Clopidogrel stop 7 days prior to the surgery. Warfarin stop 5 days prior to surgery. Heparin unfractionated 4 hours, only 4 hours before the surgery, because T-half of the heparin is very unfractionated heparin is very low, T-half very less. Okay, low molecular weight heparin you can stop 12 to 14 hours before the surgery, and ticlopidine 14 days before the surgery. Okay, now bridging drug, unfractionated heparin is called bridging drug. You need to remember this, what is the bridging drug. And disinfectant used for the blood spillage, sodium hypochlorite. You will also study this in the microbiology. What is disinfectant used in the blood spillage? Stop smoking before surgery. If you have surgery, you need to stop the smoking at least 3 weeks prior to the surgery. Pre-medication, before anesthesia you should need to go anti-anxiety drugs, anti-emetic drug, analgesic drug, antacids drug, antisilog drug, antisilog like atropine glycopyrrole, already told you. Now this is important topic, and VQ means the visual questions you should need to remember. VQ, you can see the different LMA and supraglottic devices or laryngeal mask airway. You can see here different. This is first generation. In first generation you can see LMA classic have 2 tubes. Okay, one is big and one is small, and LMA generally what is difference between first generation and this is classic. In this you see silicone. This is the silicone, made from silicone, and this you can see this unique is made from the plastics. So generally they ask about most common use this. They ask most question. Okay, in LMA Proceed they use in the daycare surgery. Okay, you need to remember the picture, and this when you see the handle like this, it means that this is the LMA fast track. Okay, when you have emergency you need to intubate, and this is gel, no pilot balloon. In you can see in every picture you see have pilot balloon. This is pilot balloon, this is pilot balloon. In every picture have pilot balloon. Every picture they have you, but here no have pilot balloon. And this is gel. You need to remember the image, and you should need to identify. Generally they ask this Proceed, they ask many times. You should need to remember. Okay, and best method to confirm endotracheal intubation is the capnography. Already this is the many times they ask in the exam. Okay, this is endotracheal tube. In the endotracheal tube have some marking. You should need to remember Murphy's eye and radio marker. What is the radio marker? Radio marker, when you do X-ray you can see this radio marker. You can see the line over the tube. This black line is the radio marker. When you do X-ray you can see this radio marker. And Murphy's eyes for protection, like when you are doing endotracheal intubation and something block the mouth like this, then air can go by this Murphy eyes, from this hole, Murphy eyes hole. Okay, now this is laryngoscope. You also need to remember this is also a VQ, visual question they ask. For adult we use Macintosh, and for children we use Miller. Okay, you see Miller is like pillar, and you can see this is also very straight. And Macintosh is like beak of the parrot. So this is used for the adults and this is used for the pediatrics. Other they didn't ask. And when you see handle, this is called McCoy. For different for difficult intubation you use McCoy. Okay, and others intubated as the radio laryngoscope, fiber optic bronchoscopy. Okay, so these are the visual questions you should need to remember. These Macintosh, Miller. Macintosh used for the adult, pediatrics, Miller used for the pediatrics, and McCoy used for the difficult intubation. Okay, you see this is the different endotracheal tube. Cuff, what is the cuff tube? This is the, you can see cuff, and this is uncuffed tube. In uncuffed tube we use in the children, and cuff tube we use in the adult. Okay, for why we use cuff? For prevent aspiration. Okay. Now this is the tracheostomy tube. Okay, this tracheostomy tube they ask question, protects this. Okay, this is Chevalier Jackson, make from steel BE. This is also tracheostomy tube. Important question VQ. You should need to remember. Then this is oropharyngeal airway, and this is naropharyngeal airway tube. Okay, they used to prevent tongue falling, and this is boggy. They give image, you see a tube have little holes on the tube. You remember stylet we use only this is also VQ. You should need to identify the devices. Okay, devices used in the oxygen delivery, oxygen delivery: nasal cannula or prong, simple face mask, partial rebreather mask, non-breather mask, venturi mask. This is very important. This they ask venturi mask. In this, why this is important? Because in venturi device we can manage the oxygen delivery according to the hole. Like you see, when you see in have color coding, and different ventimeter have different, and they have different holes, and we can manage the oxygen delivery. Okay, and high flow nasal cannula. Now how much oxygen we will deliver this mask? Okay, so you can see simple face mask, Hudson mask. Okay, simple face mask delivers 60% of oxygen, and nasal prongs, you see in movie the nasal prongs 40% of the oxygen. Venturi device I already told you, and also they ask a question in the exam. The Venturi device can manage oxygen delivery according to the number of holes. Here you can see. Okay, high flow nasal cannula 100% give 100% oxygen and 70 liter per minute, and non-rebreathing mask, this is non-rebreather mask, give 80% of oxygen, and non-invasive ventilator give 100%. Non-invasive ventilator also give 100% oxygen. Okay, cricothyrotomy. When we do cricothyrotomy, when we cannot ventilate or cannot intubate the person, it means when have emergency we will do cricothyrotomy. You remember when we discussed about this in the last step, when we are unable to do intubate by any method, we will do cricothyrotomy. Okay, here this is Selix maneuver. Okay, URE. Selix maneuver. In Selix maneuver, we will press on the cricut. Will give a exam. This is, and we are going Selix maneuver for the prevent of the aspiration. Okay, this is Megas forceps generally used in obstetrics and gynae, but here we also use. Okay, and transesophageal echo. This T. Okay, they can give picture of this. What is this? Central venous cannulation set. You need to identify. They already asked the question. They all are the VQ. Every image what I mention here is very important. Difficult airway society. Okay, what is that? We already discussed about this. Intubation, we will do try 3+1 attempt. Then we will do LMA or SGT 3 attempts, and face mask ventilation we will try after. When if we succeed, we will not continue surgery. You need to remember, they can ask question, what will do when you succeed on the face mask ventilation? You need to wake up the person. Okay, and when you fail, you need to do cricothyrotomy. Okay, now we are going to discuss inhaled anesthetic agents. In inhaled anesthetic agent, the gases are oxygen and nitrous oxide is the carrier gas. You remember in I think first or second slide I already discussed about this. What is the carrier? And I told this oxygen and nitrous oxide is the carrier gases. And what is the use of inhaled anesthetic agent? Induction of anesthesia in children, maintenance of anesthesia. This is not very important, but MAC, minimum alveolar concentration. This is important. What is MAC? This shows potency of the inhalation agent. How much potent is this? Like how much amount they need to produce the effect of the anesthesia. Like here you can see halothen is very less, 0.7. Okay, you need to remember this. This is very important. Nitrous oxide already asked in exam, and halothen already you need to know. And isoflurane 1.4, sevoflurane 2, desflurane 6. Okay, Mayer-Overton hypothesis. What is Mayer-Overton hypothesis? The lipid solubility is directly proportional to the anesthetic potency. Which anesthetic agent is more lipid soluble, the potency of the anesthetic agent is more. And this also you need to remember. What is the lowest blood gas partition coefficient? Is the desflurane. Okay, this is the fastest induction and fastest recovery, because fastest induction and fastest recovery, desflurane safe. This is also you need to know. Desflurane is the maximum greenhouse effect. Okay, this will run. Okay, so you know fastest induction, fastest recovery, lowest blood gas partition coefficient, and maximum, they produce maximum greenhouse gas effect. Now ischemic preconditioning, which like you can remember, we left epilepsy. Infuran cause epilepsy. You need to remember infuran is the inhaled anesthetic agent and cause epilepsy. Ischemic preconditioning is done by the isoflurane. You need to remember isoflurane. You can remember like this. And isoflurane used in liver surgery and neurosurgery, but they show coronary steal phenomena. You should need to remember this. They show coronary steal phenomena. Okay, halothane arrhythmia. Halothane, many questions you will find on the halothane. Halothane show baroreceptor reflex, uterine dilation, contraindicated in PPH and heart surgery, but where we use halothane? Use in the asthma, because can maximum bronchodilation, and halothane cause hepatitis, so it is toxic for the liver. So when liver is not good, you will not use halothane. Okay, sevoflurane most toxic for kidney, sevoflurane, but it is safe for heart. So we will use sevoflurane for the heart surgery. Okay, isoflurane, where is iso? Iso we also use for the heart surgery, but when you have choice between sevo and iso, you will also choose always choose sevo, because you can remember like save SAV. Okay, this fluorine safe for kidney and in obese patient, contraindicated in the asthmatic patient. Maximum gas effect I already told you. Sevoflurane make poisonous compound A. Sevoflurane make one poisonous compound which called A. You should remember. Nitrous oxides, also known as second gas effect, diffusional hypoxia, dilutional hypoxia, contraindicated in closed cavity like ear, brain surgery or intestine. We will not use nitrous oxide. Okay, what is Intonox? This is already a question. Okay, 50% oxygen, 50% nitrous oxide. First time used for labor analgesic. Ether we will give bellus anesthesia. Xenon based but very expensive. We cannot, patient cannot affect. Xenon have all the good property of anesthetic agents, but it is very expensive. This only one bad property. Okay, maximum nephrotoxicity, if they ask what is the maximum nephrotoxicity, methoxyfluorine, and MAC for methoxyfluorine is 0.16. like this is most important. When we check up see about MAC, you see MAC here we see in 0.7 for the halothane, but methoxyfluorine is lesser than the halothane of 0.16. so when they ask question which one have the lowest MAC, is the answer is the methoxyfluorine. When methoxyfluorine the answer, when methoxyfluorine is the not on the answer, then you will go for the halothane. Inert gas act on NMDA receptor. Okay, the xenon is an inert gas and it will work on the NMDA receptor. Older agent, we are talking about older agent which maximum analgesic effect is the ether. Ventricular fibrillation or cardiac arrest by chloroform CSCL3. Which agent cause hypotension when discontinued at the end of surgery? Cyclopropane. You remember the orange color, all is orange, all body is orange. Cause hypotension when discontinued. Okay, color of vaporizer. Yellow color seroflurane, purple isoflurane, red halothane, and sky blue desflurane. This is the color of the vaporizer. You need to remember yellow seroflurane, purple isoflurane, red halothane, and sky blue desflurane. Now intravenous anesthetic agent, also important, very important topic. IV anesthetic agent. Propofol, most commonly used propofol. This is the most common used When you don't when you don't know and have option propofol, you can go for you. But when you don't know the answer, you can go for the propofol if propofol in the option. Okay, so most common is the propofol used, and we can divide IV anesthetic agent in two category: propofol, thiopentane, and etomidate in one category, and ketamine in another category, because these all three work on the GABA receptor. Propofol, thiopentane, etomidate, while ketamine is work on the NMDA receptor. Okay, it work on ketamine, work on NMDA receptor, and these agents who work on the GABA receptor, they decrease all heart rate, BP, intracranial pressure, intraocular pressure, they decrease all, while ketamine is work opposite and they increase all. And now we will study single by single all. What is thiopentane? Thiopentane is, you see, thiopentane is IV anesthetic agent and work on the GABA receptor. We know this. Now stabilizing agent is sodium carbonate. In the thiopentane is the like in powder form, and what we add for stabilizing agent is the sodium carbonate. The thiopentane also named as the truth serum. Okay, this is the barbiturates. Sometimes they ask question which anesthetics agent is the barbiturates, and this is lyophilized powder dissolved in the NS. Okay, we can remember the property of thiopentane by the mnemonic of the thiopentane. From T you can remember thiobarbiturate. From H, hyperthyroidism is the drug of choice for the hyperthyroidism. You can see thyro, you can correlate like this. I is the invented intra-arterial injection, like they call vasospasm. O means pH is the most alkaline pH, 10.4, and this is contraindicated in P means porphyria. This thiopentane will do prolongation of QT interval, and they will do precipitation of calcium in the ringal lactate, contraindicated in the asthma also. Okay, and epilepsy, this is anti-epileptic drug. They also drug of choice in the neurosurgery because decrease intracranial pressure. And termination of the action by redistribution. This will from brain, this will come to blood, and from blood again go to brain, like this. This is called redistribution. Barbiturates are the conferred hypnotic activity by adding alkyl or allyl group the C5 carbon. This is the important question. Why barbiturates have hypnotic property? By adding alkyl or allyl group at C5 carbon. Thiopentane show double apnea due to redistribution. Okay. Now propofol used for TIVA LMA insertion. We use propofol, work on the GABA, already told you. Now we will remember propofol by the mnemonic of propofol. P for pen on the injection. Okay, P for pen in the injection, and P for propofol infusion syndrome. Like when we infuse for long time, we use propofol as infuser. Then propofol will do metabolic acidosis, rhabdomyolysis, cardiac arrest, and accumulation of the fat. R is reflex abolist. O, you can remember O like egg. So propofol is made from egg and egg lecithin, and can cause egg allergy. So we will not give to the patient who have egg allergy. Okay. P means is the color of propofol is pure white. They can give the visual question like in syringe have white liquid, and they can ask which anesthetic is this. Antipruritus, antiemetics, procedural sedation. Okay, or you can remember O like egg allergy and already. And this is the F. From F you can remember propofol is the pro drug. Okay. L, leave it open for the less than 6 hours. When you open more than 6 hours, this will degrade. Okay. And From you can Propofol D. D is the generally used for the daycare surgery, because onset of action very fast. 15 seconds you need to remember. Only 15 seconds it will work, and dose also 1.5 to 2.5 milligram per kg. Metabolism in liver, excretion in the kidney. Yes, you need to remember after giving propofol, sometimes patient have a green color urine. So they also ask question in which anesthetic agents you get green color urine. Induction agent of choice in malignant hyperthermia. When you have malignant hyperthermia, what is the induction agent of choice? Propofol. I already told you malignant hypothermia is very important. Everything you need to remember about malignant, like capnography, what is the agent, in which gene this is located, everything, and what the treatment. Now ketamine. Ketamine, you know, I told you the ketamine have the separate. They increase all and work on the NMDA receptor. Okay, and keep it up. What is the work of? We can remember from K. We can remember keep it up. Heart rate increase, blood pressure increase, like shock, hypotension. Where we use shock, hypotension, and blood loss. And excitatory delirium hallucinogen. E means delirium and hallucinogen. TOF, tetralogy of folate, cyanotic heart disease, agent of choice. This is the agent of choice in the TOF. Asthma and analgesic, drug of choice for the bronchodilation, ketamine. And mouse secretion, they increase also increase mouse secretion, also increase intracranial pressure and intraocular pressure, so contraindicated in neurosurgery. And nystagmus, when you give ketamine, you can see nystagmus, and this is the NMDA antagonist, we already told you, and this is used in the emergency surgery. And this onset of action is 15-20 seconds. They will not ask in the exam. Can do, you need to remember this. Ketamine can do dissociative anesthesia. Okay, you need to remember this. Class of drug, this class of drug is phencyclidine derivative. You need to remember this also. Okay, now then etomidate. Etomidate is the, you can remember E like pain in on injection. They already asked question which anesthetic agent can cause pain on the injection. Okay, and this is most emetogenic. And you can remember Tom like a person who have jerks, so myoclonic jerks. And I is the imidazolone derivative. Okay, when you can remember, can you tell me the name of the imidazole derivative amino acid? You can comment when you know. Okay, etomidate, it is also imidazole derivative. And date, you can remember date, when you go on the date have with heart, so this is drug of choice for the cardiac surgery. Okay, now what is the side effect of the etomidate? Etomidate side effect is the adenocortical suppression by suppressing 11 beta hydroxy enzyme, and by this steroid hormone will decrease. Onset of action and dose is not important much. Methoxytol is the barbiturates, and drug of choice is ECT, this is the drug of choice for the electroconvulsive therapy. Methoxytor is the barbiturates. And one more, remember one barbiturate we study in the first. This is thiopental is the also barbiturates. So they can ask which anesthetic agent is the barbiturates. So today till here we will discuss again after the, remaining part in the next lecture. I think we will cover this all topic anesthesia in the 2 lecture. Okay, thank you.